Thank you, Dr. Venkatesh. So I think, like he said, we'll just have to imagine, the cortex and vitrectomy part will follow lately. We're just going to go to the different IOL options when we have a posterior capsule rupture. So the options here could be a posterior chamber. The IOL could either be placed in the sulcus or could be placed in the bag. Anterior chamber, sleeve supported or iris supported. Now the decision where and what lens to place would depend upon the amount of support we have, the anterior capsule and the posterior capsule. For that, it's important to be able to gauge the amount of capsular support. It's very important to have a large pupil. I think the previous speakers have highlighted it's important to use maybe devices like iris hooks so that we have good visibility. And before IOL is placed, it's important again to remove as much cortex as possible, almost 100% if possible, because that is what the main problem is, and the vitrectomy as well. Once we have a rent, our main goal is in removing the nucleus, and then it's the IOL. We don't think about the cortex and the vitreous so much. So that is also very important to be taken care of. So in terms of pupil good visibility, I'm just showing a clip where a rent occurred during the last piece emulsification, and in order to have good visibility, we're using the Greisch-Haber iris hooks. So this makes it easier for us to aspirate the cortex, so you know where the cortex is, and you can place the Simcoe right in the bag, not too anteriorly or too posteriorly. And in that case, you'll have vitreous prolapse. And you can also use visco expression of the cortex. So I normally use a Simcoe when I have a rent. Sometimes if there's no vitreous, then we could also think of an automated irrigation aspiration. So once the pupil is taken care of and the cortex has been removed, the rent is somewhere in the center, and it's kind of a punched out small rent. So now we are planning to have a larger capsular Rex so that the IOL can be placed in the capsular bag for capsular fixation. So double Rexus is done, because if you have a small Rexus, we have a lot more stress on the posterior capsule and the rent can extend. So in this case, like we heard from Dr. Venkatesh, always use a single piece foldable if you're planning for a capsular fixation of the lens, because these lenses are much more capsular friendly, and the trailing haptic you can see here can be bent over the optic and then released, unlike a 3-piece lens where you'll have to dilate. In that case, the rent would extend. So it's important to use a single piece, either this is an Auroflex, even the single piece Acrosoft lenses, all those are good choices in these conditions. If you don't have enough support, then go for the 3-piece lenses. So this is a situation where there is a large posterior capsule length, and the IOL placed is a 3-piece acrylic lens. The IOL is placed in the sulcus. Do not place a single piece. That I think is very important. I think all of the speakers here would agree with that. So always use a 3-piece lens for the sulcus. If it's a rigid lens, then you can consider using a single piece also. Now here you see, because of the vitreous which is still there, the IOL does not center well. So it becomes very important to do a good vitrectomy first and then plan for the IOL implantation. So to take care of the vitreous, you first, the vitreous at the wound is cleared, and here I'm using 1 hour to cut the vitreous tan. Just by sweeping, we can actually make out if there's any residual vitreous. So now the lens center is much better once the vitreous is removed. And as you sweep, if you find that either the iris or the lens moves, then it is an indication that the vitreous is still persisting. So we'll have to go back and remove any vitreous available. So in this case, another option is also to use pilocarpine, but that you could do only after you remove the viscoelastic. So you want to remove as much vitreous first. And then here, for the final strands, using automated vitrectomy, always prefer using a bimanual vitrectomy. And if you can see, the bevel of the probe is facing down, because the vitreous is like a slinky toy, as we all know. We don't want the vitreous to come up and then turn towards the probe. So we want to have the probe facing down, unless you are too close to the PC or close to the iris. Otherwise, always make sure that you have the probe facing down. And then you use pilocarpine once you remove the viscoelastic and ensure the pupil is down before you close the case. So if you plan for a posterior chamber IOL, then always go in for a larger optic, at least 6mm optic. Capsular fixation, I think we have spoken about this. And if we have only the sulcus, we have only the anterior capsule, ensure that the haptics are well supported. The optic does not matter so much. The haptics have to be placed well. So this is a posterior polar cataract. You can see there's a posterior capsule tear here. So this sometimes we see in posterior polar cataracts. If the patients have had trauma, then this you already start off with the rent. So we don't do a hydrodissection, do only a hydrodelineation. So the bevel down phaco probe with more controlled aspiration and irrigation, the epinucleus is removed. So you can see the posterior capsule tear in the background. That is the PC tear, and then the cortex is also removed like Dr. Menu showed. As long as there is no vitreous, it's still fine to go ahead with automated aspiration techniques. And in this case, a 3-piece acrylic IOL is placed. It's better to go in for a 3-piece lens when you have such linear slit-like tears, because a single piece can easily slip through and you might have a dropped lens. And in this case, the rexus is a little smaller than the optic, so the optic is captured in the capsular rexus. But in case there's a large rexus, it does not matter, because if you have a 3-piece lens but placed well in the sulcus, the chance of decentration is quite rare, but only that the support has to be adequate. This is another posterior polar cataract, and you find the posterior capsule plaque is there. So this plaque is adherent to the PC. So it is not to clear the visual axis. This plaque is being removed. So as the plaque is being raised, you see the capsule also turns with it. So this opening is made using a microrexus forceps. It's difficult to make a capsular rexus here because the PC is very thin, but at least trying to make a central posterior capsulotomy, making it as small as possible so that we don't lose much capsular support. Again, what I wanted to show here is even if we don't have a continuous capsular rexus, you still can go ahead with a single piece lens. Just ensure that both the optic haptic junctions go into the bag. And with these lenses, because the memory is so good and they unfold very slowly and controlled, you can manage to tap both these junctions below the anterior capsule, and this opens up with very less trauma to the capsular bag. And now, because the lens is kind of plugs the capsule rent, it is safe to do an irrigation aspiration and remove as much viscoelastic as possible. So other patients with capsular fixation, the IOL is in the bag, but here if you see the haptic, it is not a vertical linear tear. So if it is horizontal, then you can think of having it placed vertically as well. In terms of zonular dialysis, just one small point. If it's a small dialysis, I think the IOL itself will take care of it. The haptic of the lens will act like a CTR and stretch the bag in that side. But if it is a large dialysis, moderate to large, then it is important to use a capsule tension ring. This is a patient who post-op had IOL decentration. So you can see that the capsular bag is folded here. And the IOL is being placed in sulcus. The inferior support is very important. Either if a dialysis or a rent, if the inferior support is not adequate, I think you should think twice where you are placing the lens. So IOL first is being explanted here using a spatula and a lens holding forceps. You can see the lens bag, the capsular bag is being folded inferiorly. Now thankfully in this patient the rexus was intact. So the first thing is to distend the bag using viscoelastic and then hold the bag. These are like an iris hooks which can be hooked onto the capsular bag. This is placed first before placing the ring, because this way you ensure that the ring goes into the bag. Otherwise, placing the ring straight away, you might enlarge the dialysis further. It might not go into the bag. So use those hooks first and then place the ring in the bag. And once that is done, it almost acts like it's a normal capsular bag, and the IOL can be placed in the bag. And these hooks, they would stay until the end of the surgery, so that the IOL implantation becomes easier. Otherwise, you'll find there's more floppiness of the bag. The other options would include the anterior chamber lenses, scleral supported and iris supported lenses. Anterior chamber, the sizing becomes very important. That I think probably most of the complications happen because lens is too small or lens is too large. That becomes important to measure the horizontal wide to wide. Scleral supported, we have the suture techniques and the sutureless scleral fixation, the glued IOLs. I'll be talking a little about the iris supported lenses, both the sutured iris supported and the sutureless, the iris claw. So here is a technique where in a aphakic patient there is no capsular support and a rigid IOL is planned. So we're taking a bite on the iris. This is a 10-0 proline suture on long curved needles. This is made by Alcon, and 2 bites are taken with the same suture needle on the opposite meridians, exactly opposite to each other. This is where we will intend to fix the IOL to the iris, and the suture from below the iris is retracted using a Coughlins hook and externalized using a McPherson's forceps. So the right side suture is placed separately, and the similar maneuver is done for the left side loop as well. So we have the Coughlins inserted, and it's pulled out. It's flushed to the posterior iris surface, so that way the suture comes out quite easily. So any secondary procedure, iris fixated oscillation, it's important to do a good anterior vitrectomy, so there should be no vitreous at all in the anterior chamber. And then the right side suture is looped around the leading haptic of the iris, at least about 2 or 3 twirls. So this will help the lens to stay in position, and the suture will not slip out from the haptic. And the IOL is placed in the sulcus. So once that is done, this suture is pulled so that there is not much of a extra suture left. And the trailing haptic is also fixed in a similar fashion. It's also, the suture is twirled to the trailing haptic. So while doing this, it's important to ensure that the suture does not slip from the haptic, but that normally doesn't happen because you're passing it at least twice. And this pull on the sutures will ensure that the suture still includes the haptic. In order to tie the knot, a side port is made, and the suture is externalized to the side port. So both the suture ends now pass through the side port, and their sutures are cut and they are tied together so that the knot is on the iris. Through the side port, the knot now lies on the iris. Now I particularly like this technique because when the scleral supported lenses, we always have a concern regarding infection or suture irritation. That is always a matter of concern. Whereas here, the suture lies on the iris, and long term also we don't have any concern about the suture degradation, etc. The second haptic is also fixed in a similar fashion. So the last clip is the iris claw lens. This lens is again ideal if you're having a round pupil which can constrict, and the IOL is first placed in the anterior chamber. So this haptic here has a small gap, and this is what is used like a clip to the posterior surface of the iris. First the lens is held and the IOL tilted so that one haptic goes towards the posterior iris surface, and using a Sinskey hook or any cannula or spatula, this is enclaved. This haptic is enclaved, and this is also repeated for the second haptic as well. Now this is overall the length of this IOL is small, but because you're fixing it to the iris, it stays there, and there's not much of a problem with decentration of the IOL. So finally, after IOL implantation, it's important to remove as much viscoelastic as possible. Dr. Venkatesh, I'm sure, agrees. Being glaucoma surgeons, they would want us to remove as much as possible. Check to see if there are any vitreous strands. End of it, just sweep for any vitreous strands. Always constrict the pupil if you're not sure, and suture the wound. I think if there is not much vitreous, you're absolutely sure the pupil is around, no vitreous, 3 mm or smaller wounds, sutureless is also fine. But anything above 3 mm, the wound is extended, it's always better to do place a suture. Or if you have had done anterior vitrectomy, which is extensive, again the eye becomes hypotenuse. So there also you would want to suture the incision. And post-op care is extremely important. Just stop with the intra-op management. So in conclusion, it's important to identify the tear early, assess the extent of the damage, try not to increase the size of the PC tear, manage the cortex and vitreous well, and place the right kind of IOL. So thank you.